risk factor, telling us that apart from talking about cholesterol, exercise, smoking, sugar control, nowadays cardiologists like us have been also talk about the importance of sleep apnea in the overall management of patients with coronary heart disease, including acute coronary syndrome. We know that due to the obesity epidemic, the prevalence of obstructive sleep apnea has increased all over the world, including in our Southeast Asian regions as well. And in Singapore, we found that 1 in 3 Singapore residents, in fact, have obstructive sleep apnea. And I suspect that the prevalence in Indonesia is probably similar as well. The patient typically presented with snoring. If you or your family members have very loud snoring at night time, you probably have to think about whether this person has obstructive sleep apnea or not. And sometimes during night time, the person also choke, have a gasping, and also frequently have to wake up to visit the bathroom as well. During daytime, patients with OSA typically present with excessive daytime sleepiness. They find themselves very tired, and they take nap in the afternoon. They commonly find a very poor concentration, poor memory, affecting their study and also affecting their work. Some of them have decreased sex drive and also frequently involved in motor vehicle accidents. Years ago, we actually conducted this very simple mechanistic study looking at the association between OSA and corneal plaque phenotype composition and also amount of corneal plaque burden in patients with coronary heart disease. And in this very small study of around 93 patients, we found that obstructive sleep apnea was not associated with corneal plaque composition using the virtual histology. However, we found that obstructive sleep apnea patients have a higher amount of corneal plaque burden. And of course, nowadays we know that plaque composition is not something very important, but in fact, the amount of corneal plaque in the vessels actually play a more important role in the prognostic implication of the patient with coronary heart disease. And we did these multi-center studies years ago, including more than 1,300 patients who underwent coronary stenting, and we monitored this patient over a period of 2 years. We found that patients with obstructive sleep apnea have a higher incidence of adverse cardiovascular event, and that average of 2 years follow-up, the patient in OSA group, which is represented by the red line here, have an average estimated event rate of 18.9% versus 14% in the non-OSA group, as represented by the blue line here, with an absolute difference of 5 percentage points and a p-value of 0.001. And important to highlight that close to 70% of this patient indeed is acute coronary syndrome presentation, which is make our presentation here relevant to this particular conference. And similarly, we also conducted another observational study on patient after coronary bypass operation. We compare patient with versus without obstructive sleep apnea in their cardiovascular outcomes after bypass surgery. We have something similar as we observed early on. At the 2 years estimated event rate was 14.7% in the OSA group, as represented by the red line here, versus 7.8% in the non-OSA group in the represented by the blue line here, with an absolute difference of 7 percentage points favoring patients with non-obstructive sleep apnea, and this turned out to be statistically significant, suggesting that obstructive sleep apnea, if untreated, will lead to a high incidence of adverse cardiovascular event in patients after both PCI and also bypass surgery. This is a study specifically looking at patients with acute myocardial infarction, STEMI, and we performed a systematic screening of obstructive sleep apnea in patients who were admitted with STEMI, and we found that the prevalence of obstructive sleep apnea was very, very high, and up to 42% of them actually have a very severe form of obstructive sleep apnea, nearly 1 in 2. And on follow-up, we also found that patients with severe obstructive sleep apnea untreated have a survival, meaning that they have a higher incidence of reverse cardiovascular event as compared with a patient without severe form of obstructive sleep apnea. And therefore, until now, we believe that we have enough argument, enough data to recommend screening of obstructive sleep apnea in patients who take in with acute coronary syndrome. But the question becomes, should we do it while in the inpatient or to do it as an outpatient when patients are more stabilized? Here, this slide tells us that how our body fluid distribute, and this is relevant in the context of acute myocardial infarction, because people in patients who have acute myocardial infarction would have some degree of myocardial dysfunction due to the ischemia, and that would lead to fluid retention. During daytime, patients are standing up. Lots of time the fluid are being accumulated in the lower limb. However, during nighttime, when patients go to bed and sleep, the fluid will be redistributed, and the fluid retention will go to the neck, will be worsening the upper airway lumen, and therefore worsen the severity of obstructive sleep apnea. And in this particular study, it would be good to have one patient who came in with STEMI. We performed an echocardiogram and also sleep study during index admission, and then repeat the echocardiogram and repeat the sleep study at 6 months follow-up as patient getting stabilized. You can see that at the top left hand corner, patient with all the apnea index, which is a measure of severity of obstructive sleep apnea. Overall, you can see that it decreased from baseline during index admission for AMI, and then to 6 months follow-up. And then we categorically divided this 101 patient into OSA group, obstructive sleep apnea, central sleep apnea, and then the non-sleep apnea group. You can see that the reduction in the apnea hypopnea index only happened in the OSA and the central sleep apnea group. And then the next thing we did was to correlate the change in the apnea hypopnea index with all the echo parameters. And we found that as the left ventricular ejection fraction improved from baseline 6 months follow-up, the apnea hypopnea index will reduce, will improve. And then as the left ventricular end systolic volume getting smaller as the left ventricular function improves, and at the same time the apnea hypopnea index also improves as well, suggesting that our hypothesis that sleep apnea during the acute MI is due to the left ventricular dysfunction is valid. And then finally, we categorize the patient into different kind of sleep apnea at the baseline. OSA in black color, central sleep apnea in green color, and non-sleep apnea in the blue color. So when we repeat the sleep study 6 months later, we found that around half of the patients with obstructive sleep apnea in the baseline resolved. And then nearly all the patients with central sleep apnea at the baseline, they converted to obstructive sleep apnea. The patient found out their sleep apnea at the baseline, the status remains the same at 6 months follow-up. So what is the implication and the finding summarized here? That American Heart Association has already incorporated sleep health into the cardiovascular health, and therefore cardiologists need to know something about sleep apnea. We know that OSA is associated with coronary plaque burden. More severe the OSA, the higher coronary plaque burden. We found that OSA independently predict adverse cardiovascular events in patients undergoing PCI and also bypass surgery. We found a high prevalence of OSA during the acute phase of acute myocardial infarction, and this is partly related to the left ventricular dysfunction. And approximately half of the obstructive sleep apnea resolved as the left ventricle recovered at 6 months follow-up. And therefore, we suggest that the screening of obstructive sleep apnea should be carried out at 6 months follow-up after acute myocardial infarction until the left ventricular recovery has completed. And thank you very much for your attention. Have a nice day.
Thank you very much, Dr. Madi, for a comprehensive presentation regarding the obstructive survival. So we have still 5 minutes to have discussions. The panelists, please comment on the presentation of the speakers. Thank you, Dr. Madi. Maybe first I think the comment regarding the second speaker regarding rosuvastatin because Ronnie is my best friend actually. So actually as I've heard about the risk of and benefit of using rosuvastatin compared with orvastatin, especially in new onset of diabetes. So what do you think regarding trade-off could be happen between benefit and risk of patient, especially now? So also the using of the targeting of the LD is supposed to be how low is supposed to be can do as you know is the lowest is better. Really, is it benefit or not? Is it too low? Is it for the patient to get? Some trial also mentioned regarding the Jupiter trials. They're using in middle of the epidemic. They also add statin, also statin, especially in decreasing CRP. And then he said he saw that application also for the using of rosuvastatin. Interesting. Maybe for the Ronald Lee, maybe one comment regarding on the very interesting using structural sleep apnea. As we know, most our patient is syndrome chronic is sometimes around 40-80% they get sleep apnea. And then how about the using of combination with the CPAP for is it will be improve the patient clinical or also the prevent of the syndrome chronic. Maybe that's my comment for maybe hospital. Thank you.
Thank you very much, Dr. Junior. I think regarding the use of rosuvastatin and also regulation and diabetes, we still need more data in the case of the treatment. But maybe in our clinical practice, I think it is good for us to try. And we also know that regarding the target of the LDL, it is not easy to reach 55 milligram per deciliter in every each of our patients. That's why I think what we can do is we try our best. And also, whenever I have a discussion with our colleagues, they suggested that you can say that you can add rosuvastatin as high as you can add, maybe about 40 milligrams, and looks to every 4 or 8 weeks. And after that, you can decide whether you can add another agent or statin. And for the lower risk of the patient with cardiovascular, I think in our clinical practice, I think below 70 is good. Not easy. Maybe other countries can.
Thank you for the question. In terms of using CPAP therapy for patients with acute heart function, what we know is that using a CPAP certainly improves the quality of life of the patient. That's for sure, and repeatedly demonstrated. In terms of cardiovascular outcome, unfortunately, there are very limited data. There are altogether 3 randomized clinical trials, and only one specifically for acute coronary syndrome. And the finding is negative, unfortunately, as some of you know. And the reason is that the compliance to the CPAP was very, very low, less than 3 hours for that particular trial. And therefore, clearly so that know that when you give a patient why put the drawer, that's not use it, it's not going to help. And that's why a lot of education still needs to be done before we could further evaluate the option of using CPAP on these patients.
Okay, this is Dr. Susila. Some comment.
Thank you, Dr. Dabson. Maybe I need to comment from the speaker. we agree that potent antiplatelet this is indication, strong indication for the ACS patient, and probably we choose if have no potent antiplatelet or contraindication for the potent antiplatelet. But we must remember many patients with the ACS is comorbid with the he need for the oral anticoagulation. As we know, not many data to supporting combination with the potent antiplatelet with the oral anticoagulation. How we treat the patient like this? And I have read that sometimes the doctor can pick a dual antiplatelet for the 1 month, and after that the potent antiplatelet will be escalation, and after 1 month the patient will be treated with the clopidogrel and the anticoagulant. Do you have data or supporting data? Is any data to combination for the potent antiplatelet with the oral anticoagulant?
So the question is there any data in combination oral anticoagulant and potent?
Yeah, I think the guideline already stated that the patient with ACS and undergo PCA do have indication for oral anticoagulant such as the therapy indication with high cholesterol. Then we have to do a treatment with oral anticoagulant with whether the potent and aspirin for 1 week. And then the patient will have inhibitor and oral anticoagulant regularly, and then to 1 year, and then only oral anticoagulant the rest of the time.
So is it the first one? Is that these potent people with potent antiplatelet?
But actually, I didn't have so much experience. It's still an disturbing situation for increasing the high-risk bleeding. I myself will consider the HBI profile of this patient. If he do have a high risk of bleeding, but do have high risk for stroke because of regulation like the high cholesterol, I will do triple with the and ASA with anticoagulant for 1 week. But if you do have a high risk for thrombotic coronary event, then I will still the potent and ASA and anticoagulant for 1 week. So it's really depends on my perception of the risk of bleeding or the thrombotic risk of this patient.
So it's individualized.